Good evening, everyone in US, and good morning, everyone here. We're going to go ahead and start. I think some of the panelists will be joining shortly. I don't know if Dr. Ichipuria has joined or not yet, because she was supposed to give the first talk. I just talked to her a few minutes ago, and she said she will be there.
I'm here.
Oh, okay, great. Thank you. Okay, so let's start. Good morning, everyone here in Pakistan, and good evening in US. And I'm going to basically introduce the panelists first, and I'll be here moderating the session. And we have a very eminent group of people in the panel. Dr. Ihtisham Mahmood, who is the past president of SCAI, I think, I'm not sure if he has joined. He said he was in a meeting and he will be joining maybe a little bit later. He will be here. Dr. Ichipuria, she is the current president of American College of Cardiology. Thank you very much for spending time. I know you were busy in meetings of ACC in Florida, and you were still able to spare time to come to our meeting, and I really appreciate that. Thank you very much. Dr. Henry, who is the current president of SCAI. I've been trying, we actually met in Japan, and I still remember that dinner we had together and great time over there. We have been trying to get him to Pakistan, but unfortunately this year we were lucky to have you at least on Zoom. So thank you very much for being here. Dr. Habibur Rahman is from Pakistan, Shifa International Hospital. He's very senior cardiologist, interventional cardiologist, who is heading Shifa International Hospital, and he came back from US a while ago. Dr. Shahriyar Sheikh will be here also. He's also a very senior cardiologist, mentor of a lot of cardiologists, and teacher of a lot of cardiologists in Pakistan. He'll be here too. Dr. Nadeem Kamar, I'm not sure if he's there, but he's supposed to be here also. He's the executive director of National Institute of Cardiovascular Disease. Dr. Azhar Farooqi from Pakistan, again, very senior cardiologist. Most of you will be knowing him. He has contributed a lot in terms of cardiology in Pakistan. He also moved back from Emory University a long time ago and worked at a National Institute of Cardiovascular Disease as an executive director and at several other institutions as well. Professor Nadeem Rizvi, I would request him to come to the podium also. He's current president of Pakistan Society of Interventional Cardiology. Dr. Azhar Kiani, again, he's a immediate past president of Pakistan Society of Interventional Cardiology. Professor Zainab Samad, she's the chairperson of medicine at Aga Khan University, and she moved back from US a little while ago, and she's heading that department. She's also a cardiologist as well. So we are going to go ahead and start. Dr. Samad, Abdul Samad will be joining us shortly as well. So our first talk is going to be on top interventional trials from ACC 2021, sorry, by Dr. Ichipuria. Please note that it's a 12-minute talk, everyone. I'll remind when 2 minutes are left, and we would try our best to stay on time. Thank you very much, Dr. Ichipuria. Please go ahead. Can you unmute yourself, Dr. Ichipuria? You are mute.
Okay, there we go.
Yeah, now
Sorry
we can.
about that.
That's okay.
Okay. Well, I want to congratulate you, Bashir, on a really fantastic meeting. You have, great faculty and great content. Really impressed with all the live cases and what you've put together. So I know I only have 12 minutes. So I want to get started on my the top late-breaking clinical trials from ACC 21. And let's see. Having a hard time. Okay, so I have no disclosures for this talk. I've grouped them into starting off with some antithrombotic, anticoagulant trials. The first is the adaptable. This is a trial that looked at the effectiveness of 2 doses of aspirin, 81 milligrams and 325 in high-risk patients with coronary artery disease. And they looked at all-cause death, myocardial infarction, stroke at 12 months. This occurred in 7.3% of the 81 milligram group, and it's similar in the 325 milligram group. They looked at major bleeding also that requires a blood transfusion, and really there was no difference between the 2 aspirin arms. So really the adaptable trial failed to show any difference, failed to show that the 325 milligrams was superior to 81 milligrams of aspirin. And I'm a visual person, so I like to see this. This was a pragmatic, multi-center, randomized, open label trial that looked at about 15,000 patients. And really the take home from this trial was, if the patient is not on aspirin, use 81 milligrams. If the patient is on 81 milligrams, keep them on 81 milligrams. If they're on 325 milligrams, well, they can potentially stay on 325 milligrams. The next is the Talos Ami Trial. And this basically looked at ticagrelor versus clopidogrel in stabilized patients with acute myocardial infarction. This was a prospective, multi-center, randomized, open-label trial. Again, about almost 2,700 patients. These were all patients that had an AMI that underwent PCI with a drug-eluting stent, and they all received a month of aspirin with ticagrelor without any clinical events. Then they were randomized after the first month into aspirin plus clopidogrel versus aspirin and ticagrelor. And then they looked at the primary endpoint, which was MACE, which was CV death, myocardial infarction or stroke, or BARC bleeding type 2, 3, or 5. And really, if you look at the primary endpoint, it was 4.6% in the aspirin and clopidogrel arm versus 8.2% in the aspirin and ticagrelor arm. Now, if you looked at just cardiovascular death, myocardial infarction, and stroke, really not significant difference, but the BARC 2, 3, and 5 bleeding was 3% versus 5.6%. So the take home from this is in acute myocardial infarction patients who were event-free during the first 30 days after their index PCI, de-escalation to clopidogrel-based dual antiplatelet therapy was superior to continuing the ticagrelor-based dual antiplatelet therapy in terms of net clinical benefit, which was really primarily driven by the lower bleeding events. The next is the aspirin versus clopidogrel for chronic maintenance of monotherapy after a PCI, the HOST Examine trial. And really, this just looked at the safety and efficacy of clopidogrel versus aspirin monotherapy in patients that had completed their required dual antiplatelet therapy post-drug-eluting stent. So this could have been from 6 months to 18 months. And the primary endpoint was all-cause mortality, myocardial infarction, stroke, readmission, and from acute coronary syndrome, major bleeding. So for clopidogrel versus aspirin, it was 5.7% versus 7.7%. So really the HOST Examine trial showed that clopidogrel monotherapy was superior to aspirin monotherapy as chronic maintenance therapy in those patients that had completed their required dual antiplatelet therapy. Again, this was a prospective multi-center randomized open label trial, which had almost 5,400 patients, 54 plus 100 patients. And these patients were initially maintained 6 to 18 months and then randomized 1-to-1. And again, I think the take-home message in this is in patients that require indefinite antiplatelet monotherapy after PCI, clopidogrel monotherapy was superior to aspirin monotherapy in preventing future adverse clinical events. If you like to see this visually, you can see the clopidogrel arm did better than the aspirin arm. And I think there's one interesting thing in the conclusion that I want to mention is that despite the positive results favoring clopidogrel over aspirin, there were some concerns that in the East Asian cohort that these findings could not be reproduced globally, and maybe the follow-up period was too short. So the long-term follow-up of this cohort will really give us more concrete conclusion about which is the best single agent for chronic maintenance after PCI with a drug-eluting stent. So more to come. The next are a couple trials that look at coronary physiology assessment. The first is the Flower MI trial. This is FFR versus angiography-guided multivessel revascularization in ST elevation myocardial infarction patients. And so this was to say, if you had multivessel disease in a STEMI patient, is it better to use FFR-guided complete revascularization type of therapy versus using angiography-guided complete revascularization in STEMI patients with multivessel disease? And so the primary outcome was death, myocardial infarction, or urgent revascularization. And this occurred in about 5.5% of the FFR guided group compared to 4.2% of the angiography guided group. So the Flower MI trial, I'm getting some reverb. I think somebody needs to be muted. So the trial failed to show that.
I'm sorry, they're checking on this side. If anyone has a speaker on, just please turn it off. Zoeb, you taking it up?
Okay, I'm going to try again. That sounds better. I think we had somebody that was not muted. So the Flower MI failed to show that FFR guided complete revascularization was superior to angiography guided complete revascularization. Again, this was a prospective multi-center randomized open label trial that had almost 1,100 patients that underwent primary PCI for STEMI and had really multivessel disease. So they randomized them to FFR versus angiography guided revascularization. And then, you know, the results were that they did actually better with the angiography guidance. And so the take home was that the strategy of using FFR to guide non-infarct related artery PCI yielded no additional clinical benefits compared to angiography guided approach in STEMI patients. And they, of course, found that the FFR arm was more expensive, as would be expected. So very interesting. And again, if you look at this, the FFR guided, they had less MACE-free survival compared to the angiography guided arm. The next trial was the intravascular ultrasound versus angiography guided drug-eluting stent implantation, 3-year outcome, the ultimate trial. This was a prospective investigator-initiated randomized trial that looked at about almost 1,500 patients. They divided these patients up into and really they wanted to evaluate the difference in target vessel failure at 3 years after intravascular ultrasound versus angiography guided second generation drug-eluting stent implantation. And what they found was that if you had IVUS guided, when it comes to target vessel failure, it was 6.6% versus 10.7%. When you looked at secondary outcome, again, you saw a difference in the target lesion failure, which was certainly less in the IVUS arm. So the conclusions were that amongst all comers of patients undergoing PCI, IVUS-guided PCI was beneficial. And IVUS-guided PCI was associated with a lower frequency of target vessel failure up to 3 years compared to angiography-guided PCI. And really all components of the composite outcome were numerically better in the IVUS-guided PCI arm. And I think now this just adds to our body of literature that says there are multiple randomized trials that now support the use of IVUS guidance for optimizing coronary stent placement, you know, as a mechanism to reduce adverse cardiac events. There were a couple of structural interventional trials that I want to talk to you about. The left atrial appendage occlusion study, the last number 3. This was to evaluate whether surgical left atrial appendage occlusion compared to no occlusion amongst patients with atrial fibrillation that were undergoing open heart surgery for another indication. And what they looked at was a primary outcome of ischemic stroke or systemic embolism at 3.8 years, which occurred in 4.8% of the occlusion arm compared to 7% in the no occlusion arm. So this trial really showed that on the background of anticoagulation, because all of these patients had anticoagulation, the surgical left atrial appendage occlusion during cardiac surgery was beneficial. Again, I like to look at this visually. 4,700 patients that were randomized to surgical left atrial occlusion plus oral anticoagulant therapy versus no left atrial occlusion. And what they looked at was this ischemic stroke or systemic arterial embolism. And they also looked at safety endpoints. But really the take home was that amongst patients with atrial fibrillation undergoing cardiac surgery, that surgical left atrial appendage occlusion on the background of anticoagulation reduced the ischemic stroke by 33% as compared to no occlusion. So again, where you see the blue is a left atrial occlusion, so you had decreased cumulative incidence of events. And again, interestingly, after the first 30 days, that reduction of 33% actually went to 42%. And there were no evidence of adverse events. And so this was additive benefit to oral anticoagulation. And my last trial I'm going to talk about is the GATI trial. This is the worldwide ST elevation myocardial infarction care 1-year results from the American College of Cardiology Global Heart Attack Treatment Initiative, the so-called GATI trial. And this the main objective was to say, could we improve myocardial infarction outcomes in low and middle income countries by encouraging adherence to guideline-directed therapy. And so they looked at data elements derived from ACC's chest pain registry, MI registry, that were collected prospectively, aggregated and reported quarterly between October of 2019 and September of 2020. And what they found was outcomes from more than 2,000 patients at 18 centers in 13 countries on 4 continents revealed that 90% of the admissions for myocardial infarction adhere to guideline-directed medication therapy. The average time for patients spent in transit to the hospital decreased by 38 minutes. Cardiac arrest upon arrival decreased, and the time for first medical contact to the use of a device also improved by 28%. So what they found was that if you can go and actually have a program in place, that we can actually impact the care of these patients. So I think GATI successfully enrolled patients with STEMI in countries generally unfamiliar with quality improvement metrics. There was definitely a trend of improvement that was observed. And GATI promotes the implementation of policies aimed to enhance outcomes of cardiovascular disease worldwide. So Bashir, I hope I stuck to my 12 minutes, but that was a quick potpourri of some of the trials. Obviously, there were a lot more trials I could have talked about, but I just wanted to stop and pick a few sort of to give us an idea of the kind of science that's been out there. So I'm going to stop here and happy to take any questions. So I think we have another speaker and then questions.
Yes, thank you. Thank you very much. Really appreciate it. You were on time, actually 1 minute earlier, so I really appreciate that.
Yay.
We will have one more talk. After that, we will have the question answer session and just a panel discussion. So our next speaker is going to be Dr. Abdul Hakim Samad, who is an AKU graduate and is a senior interventional cardiologist and director of structural heart program at New Brunswick University Hospital over there in New Jersey. So he's going to talk about challenges in STEMI PCI, bailout in difficult cases and complications. Dr. Abdul Hakim Samad, please go ahead.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. Can everyone hear me?
Yes, we can.
Okay, all right. So I've been given 3 topics and I've been asked to give it over 12 minutes. So I better get going. I do not have any disclosures. STEMI PCI is technically most straightforward and has the highest reward, and it should be approached as such. It should be kept simple. However, there are instances and technical demands that warrant a different approach altogether. I'm going to show you a couple of illustrative case examples to highlight that those scenarios. So the first is a straightforward RCA, STEMI in a 70-odd-year-old. Lesion was wired easily, aspiration thrombectomy is performed, but flow could not be established. Lesion was, the artery was ballooned from distal to proximal, still no flow, repeat thrombectomy. Patient had incessant VT, V-fed, hemodynamic collapse, had to be intubated, impella was placed, angiojet thrombectomy was eventually performed that led to resolution of flow. Still significant clot burden, and finally, after multiple runs, Dimitri flow was established. The patient had a fairly unremarkable recovery and was discharged a few days later. Along the same lines, another young guy, I'm sorry I don't have AVIs for this, but young guy presented after hours with a STEMI, left side looked fine. And on the right angiogram, first picture, I thought maybe we perforated or there's something odd, but had the courage to wire and aspirated, got lots and lots of clot out. And turned out that the patient had a gigantic aneurysm in the ostial right. Patient was placed on triple therapy, sent home. follow-up CTA was done to get a sense of how big the aneurysm is. Still had a lot of clot. 2 wire-bound stents were placed with effective exclusion. So we've all seen aneurysm causing STEMIs. Initial approach really is to get rid of the thrombus burdened by mechanical and pharmacological means, and then bring the patient back for definitive treatment. While the guidelines discourage routine use of thrombectomy, there are instances, as I've demonstrated, where thrombectomy really is essential. This has to be combined with pharmacological interventions, and if nothing worse, really just putting a stent can lead to resolution of flow. And one thing that is often overlooked is we forget about the distal perfusion bed, and aggressive use of pharmacotherapy, catheter delivered adenosine nitrite grapamol is very important. Then every now and then we'll be faced with a situation where a patient presents with culprit left main, as demonstrated by this case example. Patient presents with an LAD STEMI, has an occluded LAD. Patient was unstable, no time for a surgical consultation. Impella was placed, LAD was revascularized, and left main was stented. Patient was discharged a few days later. Another example of a similar situation, patient presented with crushing chest pain, polymorphic VT, hemodynamic collapse. Left main was occluded, was readily recanalized. A few minutes later, stented, and the patient was sent home 2 or 3 days later. So if you look at multiple registries, the frequency of left main causing ACS is anywhere from 4 to 5%. Really, these are the sickest of the sick patients, have a high burden of cardiogenic shock and impossible mortality. So if it's really the left main causing a STEMI, really angioplasty and PCI should be performed, as this is really the only chance to save the patient. On the other hand, the presentation is along the spectrum of non-ST ACS or team approach can be undertaken. Then we have instances where patients present with multiple culprits. Oftentimes these patients are hemodynamically unstable, as exemplified by this case I did not too long ago. A young patient presented with an occluded LAD and circ. The key here is to stabilize the patient hemodynamically before attempting to open the LAD and the circ. So in this case, we chose to put a balloon pump. LAD and circ were recanalized, and the patient did okay. And then we have instances where multiple approaches could be used. This is a patient who's had CABG years ago, perhaps over 20 years old, presents with an anterior wall STEMI. As you can see, the native LAD is aneurysmal, calcified, nasty looking, and the graft to the LAD is severely degenerated. So the options are either to go for the vein graft or fix the native LAD. As we all know, approaching the vein graft is really problematic in terms of long-term outcomes and then issues with no reflow. In this case, we chose to open up the native LAD. Obviously, this requires a more complex approach given the fact that these arteries are calcified. They have a heavy burden of calcium. Atherectomy had to be performed, and ultimately 2 stents were placed. So approaching the native is preferable to opening vein graft. Then in our aging population, we see a lot of severe and critical AS. These patients present with STEMIs, and then they really have bad hemodynamic outcomes. So a balloon pump Impella doesn't work in such instances. Really, after opening the vein artery, ad hoc balloon valvuloplasty has to be performed for effective salvage. This patient had a TAVR a few weeks later. Now, in the era of TAVR, especially through the Evolute platform, going through these massive platforms, engaging through guides is hugely problematic. Sometimes multiple guides have to be used. As you can see, this is a patient who had evolute a few days ago, then presented with crushing chest pain. As you can appreciate, the left main is essentially occluded by the native leaflet that's pushed against the left coronary cusp. What I found helpful is to take a root shot with a pigtail and then take any guide, try to non-selectively wire, take a guideline for a more selective approach. The left main was stented and the patient did okay. It is coming more and more to attention that patients who have had TAVR and present with STEMI, they present a unique challenging subgroup. These patients have longer door-to-balloon times. There is a very high PCI failure rate because of the inability to engage the coronary arteries. Multiple studies have been published. I'm sharing with you the most recent one from about 145 patients. About a third of them presented within a month of getting their TAVR. The in-hospital mortality is anywhere between 20 to 25%. Then, although it's relatively straightforward, you could have disasters. This is a case, straightforward RCA. It was wired, but you can see there's a small branch running parallel along the plane off the right. So this is not something you want to see during straightforward STEMI. In this case, this is a virgin chest, so patient has a chance to go into tamponade right away. Patient has been loaded with Prolenta. It's anticoagulated extremely well. So a two-guide catheter was used. Balloon angioplasty was performed in the native right. However, the perforation did not seal. So through the second guide catheter, we delivered a couple of coils and stented the main right. Patient did okay, didn't have pericardial effusion. Then there are instances where when you use an aggressive guide, you could end up in unique problems. This is a patient, elderly female, presented at 2 in the morning with a RCA STEMI. AL guide was used because of the diffuse nature of the disease. And after the first stent was placed and the balloon was pulled back there was a mechanical conflict with the guide, leading to an osteal dissection that extended into the aorta. So the osteal flap was sealed with a long stent, and then the distal was tackled.
Kim, you have 2 minutes.
There's a nice dissection flap. Following day, a CT scan was done that showed resolution of the hematoma. And then there are other subsets one has to be mindful of. Young females, pregnant females presenting with STEMI is one of the worst and the most difficult situations to be faced with. SCAT can be hugely problematic. Sometimes you have anomalous origin of the culprit artery. AL guide is really your friend in those instances. And always watch out for ramus or high OM culprits. These are ones that are often missed. Extreme angulations are very helpful. And then if there is stent thrombosis causing a STEMI, it's very, very important to image, make sure undersizing and malposition is ruled out and the stents are appropriately post-dilated. So in summary then, STEMI PCI can present unique technical challenges, not always straightforward, yet the ultimate form of sophistication is simplicity, and simplicity has to be kept as the key. These are really instances where you really make an impact on patient survival. Having a solid team is instrumental, and be prepared for the worst. Complications will happen. Important not to panic and have a thoughtful approach. Thank you for your attention.
Thank you very much, Abdullah Hakim. Nice overview of interesting cases and the challenges we face during primary PCIs. So now we are going to have like 5 to 10 minutes of question answer or discussion. So any comments from the panelists or any questions before I ask and the audience? What is it?
Dr. Ishpur, this is an excellent review of the 2021 trials for ACC in 12 minutes. Just a question regarding the GARTI, this Registry Global Heart Attack Initiative that you have. If you want to enroll some of our centers in Pakistan, how can we go about doing that?
Well, your Pakistan chapter governor should have all the information about how you can enroll in GATI, and I'm sure that he could help. Muhammad, are you on the line?
I can actually answer that question because
I'm on the line, and I'm very happy to report that Dr. Bashir Hanif Center is enrolled, and we have invited at least a couple of times more, and we would be very happy to enroll more centers. Well, this is a wonderful opportunity for Pakistan to participate in GATI, and led by Bashir Hanif, we will be definitely inviting more centers as well.
Yeah, we have been enrolled in GATI for a while, actually before when it was started first time, and we got our center enrolled. And I had asked few other centers, but at that time, not many centers were interested. So, but now I think it has matured, and other centers are interested. We'll be more than happy. We are getting our report from ACC regularly. It's a good benchmark and helps to improve the quality in the cath lab as well. So any center who is interested, they can let us know, and we can help them to get enrolled in GATI. So Hakeem, I have a question, like in STEMI, do you think that aspiration is completely dead, or is there any role of aspiration during primary PCI at all?
No, I don't think aspiration is dead, but doing it routinely, although I must say I routinely do it. Over the past 10 years, I've had 1 or 2 patients who had a stroke, so I'm not sure it was related to either aspiration or they had a stroke because of their atherosclerotic burden. But there are instances where you have a massive clot burden, and I showed you a few case examples. Aspiration must be done, otherwise you get a lot of distal embolization, and if you look at the older data from about 15-20 years ago, myocardial blush is really a very powerful predictor of myocardial recovery and long-term outcomes. So while you may have good epicardial flow, if you do not effectively do aspiration thrombectomy and treat the microvascular bed, that could be problematic. So there are instances where aspiration really is the only way you could establish flow in the epicardial arteries.
Okay, thank you. Dr. Henry, like in your lab, roughly what percentage of patients are like you're using aspiration in your lab at present?
Probably about 10%. It's not, it's very selected. And I think, those are so very interesting cases, very complicated in terms of STEMI. And what I would say about the left main is very interesting. And that there are really 4 different types. It's if you have a complete occlusion of a unprotected left main, that's one thing. But there's also people, when you look at the registries, they include left main culprits, and it also includes, there's 3 other distinct subtypes, and that is protected left mains, which are very different, and then subtotal left mains that have a lesion and that have TIMI 2 flow or better. And then the 4th one is spontaneous coronary dissection. So I agree that that's it, and that's actually left main dissection in young women is more common. So left main culprits are a very unique subtype. But okay. It was a nice talk because STEMI most of the time is straightforward, but not always.
Yeah. And Sunil, in your lab,
Bashir, my question is regarding the pre-hospital arrangements and management, particularly in the context of Pakistan. And, I wonder all the experts, in the US, of course, starting with Washington State Initiative 2-3 decades ago, that really made a difference. And Dr. Echa Poria was saying that 38-minute reduction in the time of intervention, that was probably from the onset of symptoms. So do we have any initiative in any of the towns in Pakistan to streamline the pre-hospital part?
I think you probably know better. Unfortunately, we don't have any such initiatives. A little while ago in Karachi, there was an ambulance service that was started, and one of the physicians, ER physicians at AKU, had kind of started working with them to create an initiative, this kind of a thing in Karachi, and train them and make sure that as soon as this anyone has chest pain and they are transported to the labs where they are performing primary PCI as soon as possible. But that later on unfortunately died down. I'm not aware of any other such initiative in any of the other cities. You know about Islamabad and Rawalpindi area, and we have experts like panelists from Lahore and Peshawar also, and I really don't think there's any. Nadeem, are you aware of that?
Yeah, I think there is when we started our program at NICVD, there is such a thing, ambulance service is not there, but we have chest pain units where we established containers with full-fledged doctor, a nurse, ECG, under bridges in Karachi, and then we expanded the services in interior SIM. So basically you get a primary PCI within a certain period, but symptom onset is the problem that people present late. I mean, at NICVD, we have probably one of the largest volumes in the world, about 25 to 30 heart attacks a day. We were treating with the primary PCI, but the problem has been the quality, maintenance of quality, and the presentation time. The awareness is not there. So I think although the services are there, but the ambulance services and actually documentation lacks behind.
One of the major issues is awareness. Yeah.
Can I add something?
Please.
I think this is perhaps the best forum, and perhaps this is the time that our society should take an initiative, that we should develop protocols and try to implement them throughout the country. And I think we are all sitting over there as, different heads, and this is perhaps the time that we should take this initiative, learning from the experience and perhaps implement it. Thank you.
Sure.
Yes, so, this is Tim, Henry, and I would say that this is a really good opportunity to do this. I think for STEMI, it's clear cut that having primary PCI networks, regional networks, make a huge difference, dramatically improve mortality in STEMI. And I think the more important thing that the details of the protocol are not as important as having a protocol. And one thing you can really do is, and I don't know Pakistan that well, actually, but have been spent a lot of time around the world. And I think that developing systems regional systems that have standardized protocols of how they recognize STEMI and deal with STEMI in terms of adequate antiplatelet therapy, and then getting to either primary or pharmacoinvasive PCI is really important. And if you can standardize that around the whole country, you'll, number one, save lives. Number two, save money.
Yeah,
and so I think it's really worth doing it. And it's
we have,
incredibly important.
I would say, pioneers of our cardiology who have been in the system for a long time, Professor Azhar Farooqi and Professor Shahryar. I would like them to comment on that, please. Professor Farooqi, Can you unmute yourself, please? You are muted. Professor Farooqi, you are muted. You need to unmute yourself, please.
Can you hear me now?
Yes, we can hear you now.
Okay. Well, I was just listening to the two excellent talks and thinking about it. You know, I mean, I'm one of the old timers, and I started practice before the era of angioplasty, and then I had the privilege of learning it from Andreas Grundzig himself and spending time and scrubbing with him. He joined Emory after a year after I had left Emory. So I really marvel at the advancements made, and from the bulky equipment that Grundzig introduced to the slick technology of today. It is really remarkable the advancement and changes we have seen. And I think the results are there. Dr. Ishipuria, the trials she told us, just tell us as to how much we've advanced. And the technical aspects, Dr. Hakim told us the challenges and the solutions. So I really think I marvel at the progress that's been made. I think for us in Pakistan, simple things like that you pointed out, systems, developing systems so that people with SCMI can reach centers in time. I think that is what we should concentrate on.
Sure.
There's a lot of challenges, but I think Pakistan Live is one of the ways to address it.
Thank you. Thank you. Dr. Shahriyar, can you say something? You will have to unmute yourself, please.
Thanks, Dr. Hanif.
Yeah.
I think can you hear me?
Yes, we can.
I know I really appreciate all what you've been listening to. Putting in the protocols for the ambulances, you know, in countries like Pakistan, I think almost 30 years ago, Karachi did the study, and we also did the study, that people, those who waited for the phone calls, the Safarish and the muting, and just those who got on to simple transportation got to the hospital. The quicker you get to the hospital, I think that's the number one public message that we have to tell the public. And I think the people, those who arrive earlier, with infarct, even before the primary PCI era, the results were much better. So I think the first phase is public awareness. And then I think the number two is what we're talking about, that now most of like Karachi, Lahore has a pretty decent 1122 service. Those people, the transport, you know, the transportation of ECGs through the modern technology is not difficult. So I think the initiative can be taken as a pilot projects, and I think that will catch on, you know, and I think we all have the responsibility as people, those who are controlling the cardiac side in our towns. So we should get together and get on with it.
Okay, thank you. Thank you very much. I think we are, for the interest of time, we are going to move ahead. Our next speaker is Dr. Timothy Henry, who is the president of Society of Cardiovascular Angiography Interventions. He's going to talk about a kind of a difficult topic and always challenging anticoagulation and antiplatelet regime in high bleeding risk patients after stenting. Dr. Henry, please go ahead.
Hi, and so can you see my slides?
Yes, we can.
All right, perfect. So what I'm going to do is talk about, and I've changed this a tiny bit as recent antiplatelet therapy, and it really touches on the previous talks, I think, well, and I have no disclosures related to the talk. And I want to talk about three things: short DAPT or DAPT de-escalation, and then semi-cardiogenic shock and cardiac arrest and what we do for that, and then novel antiplatelet approaches. So first of all, I think what we've learned over the last couple decades is that antiplatelets and have trade-offs. And number one, our goal is to prevent ischemia, stent thrombosis, and target vessel and non-target vessel myocardial infarction. But it's becoming increasingly clearer with contemporary PCI that bleeding, both periprocedural and late, is a major issue. And so this balance determines the net clinical benefit. And I think we've seen a lot of that for the last year. And what you see, and I think this slide really shows that in terms of the temporal relationship, that acutely stent thrombosis and bleeding both are an issue, but that over time, stent thrombosis or the risk of a recurrent ischemia drops off and that bleeding continues. And I think that's what has led to the contemporary trials that we're really talking about. And I knew Dipti was going to talk about the ACC trials, which I think are really consistent with this. So my goal was really talk about what I think is now and try to put all of this data together. So a really important trial was the Twilight Trial. So there was 9,000 patients, a total of 7,000 randomized. So remember, you had to make it 3 months with DAPT. So these are patients who were stable. So they did not have bleeding or ischemic events for 3 months. And then they were randomized. So once you're stable and you're past that acute event, you're randomized to ticagrelor plus placebo or standard DAPT. And this did include both stable non-STEMIs as well as some STEMIs in the trial. And then when you looked at it, and what you saw was, and I think this was a remarkable breakthrough because it showed that stopping the aspirin had a significant improvement in outcome. And I think you saw this with the Dipti's trials from ACC as well, that it was a bad year for aspirin. And so I think it's a really important issue. There was no difference in death, MI, or stroke, so that ticagrelor alone was fine, but you had a significant reduction in your overall bleeding. So that's important. Now, there's two other, when you looked at the trial and you looked at complex PCI, you found the same thing. Decreased bleeding and no increase in ischemic events. When you looked at patients who had diabetes or like high-risk patients, you found the same thing. And so when you look at now a meta-analysis of trials, Global Leaders, Smart Choice, Stop DAP, Twilight, Chico, you see that overall, by stopping the aspirin, you have a significant improvement in decrease in bleeding, and there's no penalty in terms of the ischemic events. And I think this is a little bit surprising, and we're going to, that you found out, and it's that important, and it's probably related to contemporary PCIs and the newest generation of stents and the better technology. But I think it's a really important issue, and we have to think about this and put standardized protocols in place. And if you looked at just acute coronary syndromes, you found the same thing. And if anything, it was even more important. And the current guidelines say that this is dual antiplatelet therapy for 1 year. And I think that these new de-escalation and stopping aspirin techniques we really need to think about this, about putting it into our protocols. Now, there still are a lot of unanswered questions. When you look at this is true with and without oral anticoagulation, and we're going to come back to that. But I think with oral anticoagulation, the same thing. We know that triple therapy is a big risk for bleeding, and that stopping aspirin is better, and we're going to come back. And that is true when you look at, this is a meta-analysis and looking at monotherapy at 1 to 3 months, and you can see that overall, it's definitely shows that it's better to stop the aspirin. Now, what about STEMI? And I'll talk particularly, and I think it's worth looking at the TICO trial. So the TICO trial looked at 1,100 patients who had STEMI. And when they looked at the STEMI patients alone, you found the same thing, that dual antiplatelet therapy had a 5% MACE, or when you look at both bleeding and MACE, compared to 3.7%. So that monotherapy after 3 months, very similar to Twilight, was better. And then that was true both in the intention to treat and as treated, and even more important in the as treated. So I think it's a very consistent thing. And what you saw is really the benefit is all in a reduction of bleeding. So that stopping the aspirin after 3 months is a really important issue. And what we don't know is what do you do at 12 months? And that's a really important thing. But when you looked at in the TICO trial, there was no differences in the major atherosclerotic arrest by stopping the aspirin. And in fact, in terms of the as treated, if anything, it was better with the ticagrelor alone. So there was really no benefit from aspirin. And when you look at the patients who are on triple therapy, so oral anticoagulation in addition, the Wolf's trial and the ICER triple trial are two very important trials. And they show that double therapy, so stopping the aspirin, significantly lowers bleeding and also lowered cardiovascular events. So, and likewise, in the ICER triple trial, looked at 1 month versus 6 months of DAP, and that stopping the aspirin, this was, you could do it either way, is stop the aspirin or stop the clopidogrel. But the point is, dual therapy is better than triple therapy because there's significant bleeding with the triple therapy. And when you look overall at the overall thing, then patients, and as patients get older, a significant number of patients now are on atrial fibrillation, have atrial fibrillation, or have indications for both for long-term oral anticoagulation. And what you can see is that oral anticoagulation is better. And that's true with Coumadin. It's also true with the NOACs, or the novel oral anticoagulations. So, and you significantly decrease bleeding, and you don't pay a penalty for MACE. And I think this has been surprising, and it's an important thing, and I think we need to incorporate it into our treatment strategies. So these are actually the guidelines, and it's very complicated. But if you look at this, look at the orange. And the orange is the duration of aspirin. And the duration of aspirin in the North American is basically 1 week of aspirin. If you have a very high ischemic risk, then to keep it the triple therapy for 1 month. And if you have high bleeding, even to shorten it. But the point is, and then if you look at the European perspective, it's very similar. And so the point is, continue aspirin maybe for a week or a month, but then to stop the aspirin. And I think this is pretty consistent now with both the North American and European guidelines. Now, there is some nuances in this, and that there are DAP scores that look specifically at patients. Both the precise DAP and the DAP score show that if you actually look at patients who are high risk for bleeding versus high risk for ischemic events, you can actually nuance this. It's a little more difficult to put this in standardized protocols, but certainly doing this for individual patients, I think, has some utility. And when you look at this, you can see that the patients who had high DAP scores, that is really the patients that had the significant events. And if you had low DAP scores, there was significant decrease in bleeding. So I think it's possible that you can incorporate this, but it's important. So overall, let's look at this. I think short DAP de-escalation is applied and really decreases bleeding, and it's associated with a decreased bleeding but no change in ischemic things. I think in particular the synergy stent and onc stent, I didn't show this data, but actually have shown that short DAP works very well, and that with oral anticoagulation, stopping the aspirin is very important. And so I think the new guidelines will actually show that this is a 2A recommendation for sure. The next thing I want to talk about a little bit is cardiogenic shock and cardiac arrest, because I think in STEMI patients who present, one of the problems is that we have inadequate antiplatelet therapy. And we know that patients who are, especially patients who are arrest and patients who get fentanyl or morphine, have decreased availability. There's ventilation, patients who are sick and are vomiting, cardiogenic shock, and then sedation and hypothermia all affect your antiplatelet therapy. And we also know that almost all of the acute ischemic events occur in the first 6 hours. And this is data from the Phoenix trial, which showed Cangalore compared to oral antiplatelets showed that there was a significant reduction compared to Plavix. And you can see that almost all of the events are in the first 6 hours. And also, when you look, why does this make a difference? Because when you have intubated patients or both patients with cardiac arrest and cardiogenic shock, they have decreased antiplatelet effect with oral agents. And compared to, this is the effect of clopidogrel, which shows that it's much less effective in unstable patients. And this is actually data that looks at both ticagrelor and prasugrel and shows that your peak platelet effect is not till at least 6 hours, which misses the whole time that's where you're most vulnerable. And so one of the things that I think is an important thing potentially for patients with cardiogenic shock and out-of-hospital cardiac arrest in particular is the Cangalore. And when you have Cangalore, it's basically IV P2Y12 inhibition. You have within 2 minutes, you have complete effect in terms of you completely decrease your antiplatelet, you have complete antiplatelet effect.
Okay, and then, you have 2 minutes, please.
At 60 minutes, you have recovery, and you can see. So I think it's a very important thing to consider for your cardiogenic shock and out-of-hospital cardiac arrest. And this is the Cath trial and shows the difference between Cangalore in green and crushed ticagrelor. So if you're going to treat patients with ticagrelor, you want to crush it. But you can see the difference that you have in terms of your antiplatelet effect in cardiogenic shock. And it's not until later that you have a difference. And we've seen that now in a number of registries that this actually makes a significant difference. And I think it's an important thing to actually consider in people with the current things. And then who have out-of-hospital cardiac arrest and cardiogenic shock. And then the last I want to say, this is a rapidly changing field. And there are very unique novel antiplatelets that are on the way. And there's a couple of trials. We just actually presented data with the sub-Q dose. So this can be given in pre-hospital, and there's now 2 different agents that look at 2B3 inhibitors-free agents. And these are agents that given are very short acting and are very rapid onset, but are relatively short acting. And actually, if you look at the increase in platelet, so that you have it effect for about 3 hours. And I think this is a new class of agents that are going to be very effective and could be given in the pre-hospital thing and would be very inexpensive and potentially have the benefit to do it. So you get high-grade antiplatelet inhibition that resolves within 2 hours, and they're not affected by aspirin or P2Y12. They look to be very safe and well tolerated, and I think this is on our way. So, antiplatelet therapy is very complicated.
Dr. Henry, we're out of time.
Worse.
Can you hear me?
Yes.
Please.
And this is my last slide, and said the point is you have to plan for this, and I think the point thing is to have standardized protocols in place. Thank you.
Thank you very much. I'm really sorry I had to keep reminding.
No, that was it.
I apologize for that. Excellent overview of, I think it's a very difficult subject and challenging everyone has to face when we see a high bleeding risk patient and we have to decide about all these anticoagulants and antiplatelets. Great review. We'll have the question answer session after the next talk. I am happy to actually report that Pakistan Society of Interventional Cardiology a few years ago actually came up with the cardiac cath lab standards and guidelines for Pakistan. And later on, Supreme Court in another case actually endorsed those guidelines and made sure that those guidelines and standards are implemented in all the cath labs. And like it was pending for a while, but again, Supreme Court took this thing again about a month or two ago, and now they have asked us to implement all these guidelines and standards within like 3-4 months. So everyone is trying to have that, and I thought this will be the best time to really talk about importance of quality assurance and best practices in the cath lab by none other than Dr. Sunil Rao, who is the professor of medicine at Duke University Health Center and also is the president-elect for Society of Cardiovascular Angiography Interventions. He has been involved in this subject for a while, and I think he will be the right person to tell us what should be the minimum standards of quality assurance or what is the importance of quality assurance in the cath lab. Dr. Rao, please go ahead.
Yeah, thank you very much, Bashir, and congratulations on a wonderful meeting. Thank you again for the invitation. This is a topic that is really close to my heart. I know that sometimes it can seem a little bit boring because everyone wants to see great cases and they want to hear about the newest antiplatelet drugs, but I would argue that this is of fundamental importance to the way we conduct business in the cath lab every day. These are my disclosures. I don't have any non-research relationships with industry. My institution gets funding for my roles on steering committee for a trial that is funded by Bayer and another trial that is funded by the NHLBI. So the question ultimately is, why should we care about quality? And I would call your attention to this outstanding article written by my colleague Manesh Patel, as well as others at the American College of Cardiology, because really it is our responsibility and that we have a privilege when we take care of patients to regulate our own practice. Fundamentally, inherent in the doctor-patient relationship is our desire as physicians to use the best knowledge combined with our clinical judgment to provide the best possible care for our patients. From a more practical standpoint, if we don't regulate ourselves, others will regulate for us. And in many of those cases, which is already happening in the United States, that can create a fair amount of friction between the conduct of clinical care as well as the against the overall tyranny of quality metrics. In the United States, we actually have several competing issues that are limiting how well we can actually spread quality of care throughout our cath labs. The first of which is that we have a tremendous amount of variation in care. These are older data, but the patterns still persist even today. These are data from the Dartmouth Atlas, showing that there's a tremendous amount of variability in the rates of PCI for similar patients across the country. In the pale yellow, you can see there are very, very few rates of PCI for patients who have coronary disease. And in areas of red, there are very, very high rates. The question is all of this variation good or is it bad? It is, of course, probably appropriate to have some variation in care because we want to make sure that we tailor our therapies to the patients that are in front of us. Perhaps wide variation in care may not necessarily be all that appropriate. The other issue, of course, that we have in the United States is that we have this, which is a very, very complex and challenging medical legal system. This is a billboard asking whether your stent was unnecessary and asking patients to call a law firm so that there can be oversight of these patients' procedures. So this is what I'm talking about when I talk about the fact that there is regulation from outside of our profession. And certainly this is a fodder for lawyers to get involved. And unfortunately, many physicians have actually been sued by their patients for so-called unnecessary PCI. And in fact, some cardiologists are actually spending time in prison. The other challenge that we have in the United States is that we have a variety of low-volume operators. My colleague Alex Faneroff looked at this when he was at Duke. He's now at Penn. We looked at the NCDR that includes 10,500 operators performing PCI. We found that the median annual case volume is only 59 cases. That's about one PCI a week. And in fact, 44% of interventional cardiologists in the United States perform less than 50 cases annually. When I show these data to people outside the United States, they're quite frankly stunned at how many low volume operators we have in the US. The problem, of course, is that many of these low volume operators are operating also at low volume hospitals. So unfortunately, they don't have the luxury of having higher volume operators to oversee their practice. From a quality standpoint, most of these operators perform PCI at rural hospitals where they are the receiving centers for STEMI patients. So while we may say that we need to eliminate these low volume operators, it creates a problem with access to emergency PCI. So what is the solution to this particular problem? Well, I would argue that the solution is for us to improve the quality across all the cath labs in the United States, and effectively a rising tide lifts all boats. So as we think about this, let's start thinking about what the actual definition of quality is. The Institute of Medicine in the United States has defined quality as a degree to which health services for individuals and populations increase the likelihood of desired health outcomes and are consistent with current professional knowledge. That's, of course, what we all want to do in our clinical practice. But also what we're interested in, whether you're a cardiologist or a primary care physician, is we're interested in healthcare value. Because at the end of the day, someone is paying for this care. It may be a governmental system, it may be a private insurance system. But what we want and what patients want from their care is healthcare value. And healthcare value is the combination of quality and finance. It's healthcare outcomes per dollar spent. So let's talk about the definition of quality. And it's important to think about quality in three domains: the structural domain, the process domain, and the outcomes domain. What do we mean by structure? Structure are the ingredients necessary to deliver quality care. So for example, in the PCI setting, do you have a cath lab that has the latest imaging equipment? Do you have access to intravascular ultrasound? Do you have access to coronary physiology? What is process? Process is the application of evidence-based diagnostic and therapeutic measures. So for example, do you have protocols around how to prevent acute kidney injury in patients coming to the cath lab? Do you have an ACS pathway? And of course, all of us think about quality primarily in the outcomes domain. Is the patient alive or dead? Are they free of angina? Or are they continuing to have angina? And what is the cost of their care relative to the outcome that they receive? So as we start thinking about each of these domains, it's important to realize that none of this exists in a vacuum. These are all interrelated. And in fact, you can't have quality without having all three. So for example, the structural measures may be in place, but doesn't mean the quality care is necessarily delivered. So for example, you may have coronary physiology in your lab, but if no one's using it, that structural domain is really somewhat meaningless. What if you have an ACS protocol? What if you have an acute kidney injury prevention protocol, but nobody's using it or nobody is aware of it? Or let's say you have an ACS pathway that hasn't been updated in 10 years. Well, then the process domain becomes meaningless. And the outcomes is the easiest thing to gain. So for example, if the occurrence of acute kidney injury after PCI is an outcomes quality measure, sometimes the patient can be discharged from the hospital before that kidney injury is manifest and effectively counts as not having that outcome. So that's an easy way to gain outcomes. In addition, if you're focused solely on outcomes, remember there is the issue of risk avoidance, where high-risk patients may not necessarily undergo the procedure because of the operator's fear of higher mortality. So as I mentioned, the structural measures can be in place, but doesn't mean that their quality of care is being delivered. Process measures may be in place, but no one's using them. And of course, outcomes can be missed or gained. And remember, good outcomes are not a guarantee of quality of care. This is specifically true, or particularly true in PCI, because easy cases or type A lesions, or in some cases where there is no lesion, the PCI may be very, very successful and the patient may have a good outcome. But that doesn't necessarily mean the PCI was necessary or was a high quality PCI. What are some of the unintended consequences of QI? Well, risk aversion is a big one. When you're measuring just mortality, for example, operators may avoid high-risk cases. This is a terrific paper by Tom Boyden in the American Heart Journal where he compared two states, Michigan, which has continuous quality improvement, that is a quality improvement initiative that continually feeds back data to the participating sites, and New York State, which publicly reports their quality metrics, specifically mortality from PCI. So in the setting of New York, where the outcomes for each operator are publicly reported, there is a tremendous amount of risk aversion. You can see that on the graph, where you can see that the overall use of PCI is much lower in New York, particularly at patients who are at higher risk for mortality, who in fact would get the most benefit from PCI. So those patients are not getting PCI because of the public reporting issue. So as we try to combine these three domains of quality into something that's meaningful for those of us who are either running cath labs or performing PCI, we need to think about performance measures. So what's a performance measure? Well, it's a metric that represents a meaningful outcome to patients in society. Mortality, I think I would argue, is a very important one. Patients care about living or dying. We care about living or dying of our patients. It should be valid, reliable, and readily measured. Mortality is an easy one. You can measure whether the patient is dead or alive using administrative data or registry data. Importantly, it has to be adjustable for patient variability. We don't want to penalize centers that are treating high-risk patients. You have to have robust adjustment and risk models to make sure that high-risk patients centers that are treating high-risk patients are not being penalized. It also should be modifiable. So, if, for example, if the occurrence of AKI after PCI is considered to be a valid performance measure, we have to have some way to improve that, right? Otherwise, we're just continually penalizing operators in hospitals. And of course, it has to be practical to measure and practical to feed back to the sites. So this is very, very challenging. And the American College of Cardiology is continuously coming up with new ways to measure performance measures, as is SCAI. The challenges are, of course, choosing the right ones. How good are the data? How well are the data collected? How representative is this of the patient population that's undergoing PCI? So, for example, if you have a STEMI measure, but the hospital is not doing any STEMI patients, it's completely meaningless to that particular hospital. And of course, we've got to be able to collect the data in a timely fashion and analyze it and feed it back to the sites. These are the performance measures. I'm not going to go through all of these, but some of these you may recognize, of course. Appropriate reason for elective PCI, the patient's ability to receive dual antiplatelet therapy, prescription of optimal medical therapy. Interestingly, this first bullet, comprehensive documentations of the reasons for PCI, is one of the most common ones that's actually missing from documentation. It's amazing. If you look through the charts of many hospitals that are performing PCI, a lot of patients in their documentation will not have an indication listed for their PCI. And that's something that's relatively easy to correct. The American College of Cardiology, of course, has the Cath PCI registry that it runs in collaboration with SCAI. These performance measures are not necessarily for public reporting. They are publicly reported now if you opt in, but they're really for internal QI use only. So if you get measures fed back to your hospital, you can see what the quality of care that's being provided at your hospital is. And as a cath lab director, you can use that data to improve quality. So risk-adjusted PCI in-hospital mortality is reported for all patients and for ACS patients. Risk-adjusted PCI-related bleeding using a validated bleeding model. Now, of course, risk-adjusted post-PCI AKI is being reported, and risk-adjusted 30-day readmission after PCI. I would call your attention to this outstanding document released by SCAI. This is led by Hari Naidu and Dan Kolansky. This is the SCAI Expert Consensus document on best practices in the cath lab. This is really a roadmap for how to improve and measure quality in your cath lab, and I would recommend that everyone download and read this. There are also tools that are readily available. The SCAI has released a risk calculator that's available for both iPhone and Android. The NCDR also has both the Clinical Quality Coach and the Cath PCI Bleeding Risk Calculator that are available as apps and for use at the bedside. It is important that everybody get involved and everybody care about this. This is an important issue. It may not be the sexiest issue. It may not be the most dynamic, but it is probably the most important thing that we can do. Everybody that works in the cath lab, quality is your responsibility. Why care about it? Because it makes a difference. Look at these data from Mamas in the UK, looking at radial adoption and mortality. There was a tremendous increase in the adoption of radial approach between 2005 and 2012, and that was accompanied by a decrease in mortality over time, particularly in the STEMI patients. But we also have to recognize that quality metrics sometimes can not keep up with current data. So for example, radial approach may in fact sacrifice some door to balloon time, but the trials demonstrate a reduction in mortality, which is partly potentially why door to balloon time is no longer reported as a quality metric in the United States. First of all, everyone's doing great. So there was a nationwide quality improvement initiative to improve door to balloon times, and everyone is doing great now, so it's not worth measuring. But the other issue is that how do we incentivize newer techniques that may affect other quality metrics like transradial access? So what's the future of cath lab QI? Well, I think it's important, as the electronic health record is required now in the United States, to use that to integrate risk and decision support. Consumer-driven quality improvement is already here. There are several consumer-facing websites that measure quality of care or try to measure quality of care and report that back. All of us are being measured now. And of course, the most important thing with respect to the future of cath lab QI is improved risk modeling using machine learning or random forest plots. So to wrap up, Quality is not one-dimensional. It involves the domains of structure, process, and outcomes. It is a team effort, and it needs to leverage our current technology. It has real impact on patients, but it continues to evolve as our evidence base evolves. The classic example is radial access and door-to-balloon time. But quality is our responsibility, and I would highly recommend that if any of you are interested in this, go to the SCAI website. It is the home for resources on PCI quality. So I want to thank you again for inviting me to this important meeting, and I'd be delighted to take any questions if you have any. Thank you.
Thank you. Thank you very much, Sunil. What an excellent overview and on the importance of quality in the Cath lab. And again, I'm really happy to tell you that when we prepared this Cath lab standards document back in 2017, at that time we even used the SCAI guidelines, previous ones, to basically incorporate in that document. And all those three domains of quality you mentioned, all those three has been addressed in that document and are being implemented. And I think definitely SCAI is a great source for all these things, and we will go through this new document and see what else needs to be done and incorporate that. What I'm going to do is that because the next talk is more or less similar to this quality standards, so instead of taking the question and answer now, we will move on to the next talk, and then we will have the question and answer session. Just like this in the Cath lab standards document, we also addressed credentialing part and the training part, and we now have a proper, I would say, fellowship in interventional cardiology from our College of Physicians and Surgeons of Pakistan, and we have tried to again use SCAI standards and guidelines to implement in the training process as well. So I thought I incorporated this talk to really talk about what should be the minimum standards for training in interventional cardiology, because we are currently again, according to that document and Supreme Court guidelines, we have to credential all the interventional operators in Pakistan, and in the process of doing that. So I think to talk about this thing, just like you were the guru in quality assurance, nothing better person could do to talk about this except Dr. Hisham Mahmood. He has been a great friend. He has been course co-director for our Pakistan Live for last many years, and has been very helpful, and has giving us guidance in all sorts of issues for a long time when he was the president of SCAI, as well as even before that. And we are really, really grateful to him for helping us in all these activities and supporting us all the time. He's the immediate past president of SCAI. No, I think our Pakistani colleagues and interventional cardiologists know him very well. So I requested him to talk about the minimum training standards to practice interventional cardiology. So please, Dr. Mahmood, please go ahead. Thank you.
Great. Thanks, Bashir. Hopefully everybody can hear me. And I will
Yes, we can.
share my, okay, great. And let me work on getting my slides up. And while I'm doing that, we will, a hard act to follow, Tim and Sunil. Okay, can everybody see my slides?
Yes, we can.
Okay, great. So my disclosures that are most relevant to this talk are that I'm one of the co-chairs of the 2022 ACC-AHA SCAI Interventional Cardiology Training Standards document, which will update all of the standards, and this will be a new set of standards that will be published next year. We've been working on this for well over a year. I cannot share that document, but I will share the concepts as well as review where the current standards are. And before I go to that, you saw Dr. Henry, our current SCAI president, Sunil, upcoming president, and I don't know if either of them had a chance. I didn't see Sunil giving this intro, but I'd like to remind everybody in Pakistan and anywhere around the world, SCAI is your lifelong professional home. It's the professional medical society, sole professional medical society focused on interventional cardiology, membership around the globe. And specifically, we represent this specialty predominantly in the United States, but also around the globe. I encourage everybody in Pakistan to join, become members, because it's a great opportunity to network and meet other individuals. And as SCAI continues to expand and grow, we definitely have a long-term commitment to our international colleagues. And so just a quick reminder that it is truly a global organization. And SCAI is also the academic representation for interventional cardiology. We do this collaborating with the American College of Cardiology and AHA. But we are the organization that the American Board of Internal Medicine looks to, not only with respect to the maintenance of certification, but more importantly, what are the appropriate training standards? And as the field is rapidly expanding and morphing with substantial involvement of structural heart disease and structural interventions and endovascular interventions, we have decided to take a broad, comprehensive look to update our next set of standards to encompass what is the interventional cardiologist of the 2020s and 30s to look like, and how can we address training not just with respect to coronary interventions, but endovascular and structural heart interventions. So this is the document that I was mentioning earlier that will be published in the next few months, at which point I think this will have substantial impact on training standards for this field around the globe. As we think about training in interventional cardiology, I'd like to sort of highlight the two aspects. There's the cognitive aspects, and the cognitive knowledge base for the field is really broad. It includes coronary, peripheral, and structural interventions. And then there are technical skill sets where you have to acquire new skills and you have to maintain those skills. And as you practice in the field, new procedures continue to come along, new techniques are introduced, and then there's the issue of low volume procedures and low volume operators. Keep those in mind. In the United States at the present time, the training standards are pretty straightforward. You have to complete a 3-year cardiology, general cardiology fellowship, after which you have 12 months of accredited training in an ACGME approved program, and you have to do 250 PCIs during that training year. That's the numerical requirement. In addition, there's obviously a set of cognitive training curriculum that you have to go through, and when you take the board examination tests you on, broadly speaking, that cognitive knowledge base. To maintain interventional cardiology training, you need to do 50 PCIs a year to be able to re-credential and to maintain your certification. But when we think of our field and see how it's evolving so quickly, you look at complex coronary interventions. How do you even define that term? And are there any separate standards for that? No. Endovascular interventions, you need to do 50 in training with 25 as a primary operator to get credentialed in most hospitals. For carotids, it's 25 with 50% as primary operator. And for structural heart disease, I won't go into the numerical details, but of course we have requirements around TAVR, we have requirements around TEER or MitraClip, we have requirements about left atrial appendage occlusion, we have requirements around PFO and ASD closure. All of these requirements have numerical requirements that you have to meet, and the bulk of those are FDA mandated. So I usually give this talk to the SCAI fellows as well, and I like to go back to when I was an interventional fellow, and what did I train in? And those are the procedures on the left. And what do I do today? And those are the procedures on the right. And when I compare to what I train to what I do, especially as we look at a lot of the emergence of structural heart interventions, the question for everybody listening here is not just what are the minimum standards for any initial credentialing, but how do you make sure that we set up our field for success in acquiring new skill sets? Some of that depends on where you're practicing. The skill sets at a large academic or university hospital will be very different to a small and intermediate-sized community hospital. And the way I've sort of started to think about it, and I certainly preach this concept, is no interventional cardiologist can do all 6 of these rectangles. I do think the cognitive knowledge base everybody needs to have. From a skill set standpoint, most interventionalists should focus and ensure that they have the skill sets for that top horizontal platform. If they want to do it, you can go horizontally across that set of procedures. But if you want to do advanced areas, you really need to focus on one vertical domain: advanced coronary, advanced peripheral, or advanced structural. You should not try and do multiple domains. You will never get to be facile enough and have enough volume to maintain those skills. Our field is, of course, one of lifelong learning, and there are a number of resources that you can access from the MOC, from ABIM, the major meetings from societies in the United States and Europe. There is simulation training that in this field is becoming more important, and in the ACGME US training requirement, simulation plays a significant role. And finally, I'll touch a little bit on experiential learning, which is critical to our field. From a cognitive standpoint, there is a core curriculum that's well defined in the literature for interventional cardiology. However, how do you keep up with the new data? How do you keep up with so many publications and so much new data? And I think the key is focus on original research, look at the clinical trials that are likely to have impact on your clinical practice, look at the high impact journals in the field. Regional and national meetings and, of course, webinars have become a new source of education and training. Because our field is so procedural or technical in orientation, live case demonstrations continue to play a significant role. Working with experienced proctors is very important. I mentioned earlier simulation training in animal models, and I wanted to highlight some recent examples of success. If you think about TAVR training, by and large, this entire procedure in this field was without previous established training standards. It was initially FDA mandated. Industry did a great job in making sure that there was detailed education with simulation training, experienced on-site proctors, and as time has gone on, around the globe, we've got a pretty standardized approach to TAVR. Other recent examples would be converting from femoral to radial access and introducing chronic total occlusion revascularization around the globe. From a technical standpoint, I think maintenance of skills is very important. And one of the things is low volume procedures should really be concentrated amongst few operators and few institutions. I think simulator training will continue to play a bigger and bigger role, as might be robotic training. And for people who are otherwise in low volume places doing low volumes, find ways to get to a high volume center and spend some time every year, because even if you don't yourself practice, you'll get to see somebody else doing things that are more complex. Old quote, the things we have to learn before we can do them, we learn by doing them. And the point here, maybe Aristotle was thinking of interventional cardiology. The concept of experiential learning is most apt to our field, where we will continue to be challenged with new ways to tackle various clinical, technical issues. You learn from that concrete experience, you think about it, you observe, you reflect, you come up with a new concept, and then you experiment. The next time you do that case, you might do it a little differently. If it works, you improve and refine the technique. If it doesn't work, you know that's not something to do. That's a very, very important part in maintenance of interventional cardiology skills and acquiring new skill sets. So in conclusion, what I can share is that the training standards in interventional cardiology and broadly speaking in cardiovascular medicine are going to be more focused on competency-based training and not on time and volume-based. We will emphasize, and we continue to emphasize, lifelong learning, making sure that broadly all interventional cardiologists have the cognitive knowledge around contemporary interventional cardiology and continue to have methods by which they can acquire new technical skills. Thank you.
Thank you very much, Dr. Mahmood. Great talk. I think there will be a lot of questions and issues probably from people from Pakistan. But before we take that, I would like any comments from the panelists on Zoom first, and then I'll go on to the panelists here. Anyone want to say anything from Pakistan? Dr. Abu Rahman, do you want to say anything regarding this quality and training? And
I think that it's a matter of pride and satisfaction that we had a head start on establishing standards for cath labs and also for operators. And over time, it's maturing. It's an evolving process. So I'm very hopeful that what we have heard from Dr. Rao and Dr. Mahmood, and with ongoing involvement of Pakistan Society of Interventional Cardiology with these international organizations, will continue to move in this direction and be a lot more transparent and responsive and responsible to our patients with satisfactory outcomes that can be compared with the international standards of performance.
thank you.
Thank you.
Dr. Henry, any possibility, I know Dr. Rao is there also, he's going to be the next president and he has been involved in this too. Like Pakistan Society of Interventional Cardiology can kind of collaborate or work or with, obviously SCAI has a much longer experience in doing things, and maybe we can, whatever guidelines we have made already, can form kind of a combined committee, few members from our side and few from your side, and go through that document and see if we can improve, because we have to keep our kind of a environment and situation in mind also. But we definitely want to make sure that we are up to the mark and get to the international standards. So is there a possibility to, especially in quality and training, any way we can collaborate and work together?
So number one, absolutely. I think that it's a really important thing for, from a SCAI standpoint, our focus is on, number one, improving quality for interventional cardiologists, but also for our patients. And I think a really important part of SCAI is to focus on interventional cardiology patients. And I think, some take-home points, what you've heard from tonight is, in this session is, number one, I would say it's really important to do as much as you can to have standardized protocols in place that are based on, as best as you can, guideline-based recommendations. And I think, and then two, this is lifelong learning. I mean, it's, if all of us on the call realize how much interventional cardiologists has changed in the last 20 years, it's dramatically different. So we have to keep up. And the last thing I would say about quality is, most of us take care of patients who are local. It's in our regional area. So we're taking care of people that we, play golf with and worship with, and that's the people that we take care of. And so our goal, the ultimate most important thing about quality is, you want to take the best care of your family, of your friends. And I think both Sunil and Shami emphasize that importance of it's an individual responsibility to do the best you can. And I think that if we're all trying to do that, it'll be better. And I think SCAI, our focus is entirely to improve care for our patients, and then also to help interventional cardiologists do the best they can. So the fact is, as much as we can help, we'd love to do that.
Sunil, thank you. Sunil, would you like to say something?
It's hard to add anything to what Tim said, but I completely agree with him. I think that, first of all, congratulations to the entire Pakistan interventional community for taking quality so seriously. It's a very, very important thing. And I think it's in line with exactly what SCAI's mission is. So I think that to the extent that we can collaborate worldwide to improve the quality of care of patients undergoing coronary and structural and peripheral interventions worldwide, that is something that is very, very in line with the interests of SCAI.
Thank you. Zainab, you have to say something. You actually worked in US and now back in Pakistan and have seen both aspects. So what do you think?
Thank you, Bashir. So first of all, for arranging such a wonderful session and then having such an international panel put together. I want to make two comments. First of all, that quality, one of the unmeasured and intangible aspects of improving quality is actually employee engagement and staff engagement. The people who come in as a team to take care of the patient. And I remember distinctly as a fellow, I worked with Sunil, and you were excited to come in every single morning. And I would say that 100% of our fellows had the same feeling when we rotated with him. So that's an important aspect that needs to be somehow highlighted as we go forward with quality efforts across Cath labs and other aspects of cardiology. The second aspect is, setting Cath lab standards in Pakistan. I laud the efforts that the team here in Pakistan has done. But I would also add that the Cath lab standards are for Cath labs that are set up. In large areas of Pakistan, for example, in KP and Balochistan, there aren't many Cath labs. We have a ton of patients who aren't able to get to a facility that will open up their vessel in time, or that will be open on a weekend and so on. So I think part of improving the standards of care is also to think about where we can move our resources and where we can provide resources, and really looking at the inequities of care currently in Pakistan as well.
Thank you. Dr. Hafizullah, you're there. You wanted to say something. I know you have been interested.
Thank you.
Yes, please.
Yeah, thank you, Bashir. I think if you remember, in 2013, we had invited Azhar Faruqi to give a talk on quality. And at that time, the concept seemed to be very novel. But I think this is the time where we are registering the Cath lab, where we are credentialing the operators. I think we should have very clear aims in front of us, that we have to establish a very nice program for STEMIs as well. It might surprise Zainab to know that we have at least 24 Cath labs, even in Peshawar. And there are Cath labs in area as Swabi, Noshara. So Cath labs are sprouting up like anything. I think the quantity is there, and with the help of our PSIC, we must enforce now the standards which have to be strictly adhered to. And I think these two talks were absolutely wonderful, and we should be in close collaboration in maintaining the standards. Thank you.
Thank you very much. I would like Dr. Nadeem Rizvi, who is the current PSIC president, and we have been working together on this quality initiative in Pakistan. So, Nadeem?
I think I agree with whatever everyone has said. I think I'm very keen that we should have an inclusive. In Pakistan, the issues is there is so much variability in quality of care from places where you have state of the art, and in other places where it is lacking. I think we need to standardize, and Dr. Bashir was one of the instrumental persons in formulating this document, which is called CCL 2017, which is now my onerous job with my council to implement. And I think we will go ahead and in future, as Dr. Bashir has quite rightly pointed out, we need to collaborate and have some stand, because quality is something that is we're not very used to in third world country. We have best quality and we have very lead quality. So I think this has to be standardized, because whether you are working in US or you are residing in US or whether you are residing in a rural area in Pakistan, the disease has to be treated in a similar way to achieve the proper outcome. And I would be very grateful, and I'm looking forward to further collaboration as outlined.
Thank you. Asad, you wanted to say something?
Yes. Actually, my question was
Keep close.
Regarding the first talk by Dr. Henry, and then just from Dr. Echapuria's talk as well. We saw these two amazing talks, and what we could figure out was that based on all these trials, probably in future we'll be looking at an earlier cessation of DAPT and probably going towards monotherapy. And then we saw all this data where Plavix is better than Loprin at preventing CV complications. And then we saw the Twilight data as well, where stopping Loprin early was associated with lesser bleeding risk and everything. So in Pakistan, we have this probably a pandemic of diabetes, and the question that comes to probably most of our minds is, if we are going to go towards the route of monotherapy, will Plavix be the one where we know up to 40% of patients in several trials were resistant to Plavix? Will that be the monotherapy of choice, or should we keep Loprin with them, or should we go to something like Ticagrelor? Thank you. It's to Dr. Henry and Dr. Echapuria.
Dr. Echapuria has actually had to leave, but Henry can answer the question, please.
So, from my perspective, I think this is really challenging because it's a really important issue in terms of what we do with antiplatelets, and it's changing a lot. And here's what I'd say. Number one, it varies a lot regionally and what's available around the country. And what I would recommend for each PCI center is that you actually meet with your group and say, all right, what's our availability and what are we going to do from a standardized approach? Because, I don't know, for me, I'm sure most of you get calls, like multiple calls a week from primary care people, from your nurse practitioners, from being like, what should I do with this patient? What should I do with that? And I think if we have a standardized approach to people, it's the best thing. Taking in account of all of the rapidly changing things. But what it really shows is that the bleeding is an important issue and we need to be aware of it. And stopping the aspirin, and I think triple therapy for sure we need to avoid. And I do think that having the more potent both either prasugrel or ticagrelor available is an important thing. But it's very complicated right now, and I think what it's really good to do is get your interventional group together and make a standardized approach to do it. Do that, and then reassess it in 6 months.
Okay, thank you very much. And I think any comments or questions from the audience sitting here? Not last comment from...
Just a quick comment that, applying the de-escalation of DAPT to SAPT, very good data from US. The issue in Pakistan is a lot of centers are using older generation stents. The data we're applying to PCIs in US with precision PCI, you're using IVS in a lot of centers, and where you see outcomes and newer generation stents. So applying de-escalation to PCIs in some of the large volume centers being done over here where older generation stents are being used, I think we have to be careful with that. The other thing is ticagrelor cost issue. So, just switching to monotherapy on that is a problem. over here. So we might have to stick with the DAPT in a lot of these patients because of that. It's just very complicated, as you mentioned, with evolution, continuous evolution in these antithrombotic. I guess that could be applied based on data on the local scene.
Yeah. Unfortunately, one other issue in Pakistan right now is we don't have prasugrel available here. Ticagrelor, the one from like multinational companies, that's like very costly. A lot of people can't afford it. There are a lot of local companies coming up with ticagrelor, but unfortunately, we don't really know the efficacy of those pills. So most of the time, we get stuck with aspirin and clopidogrel. So that really becomes an issue. Yeah, I think if no other comments, we are going to move ahead. We are a little bit behind on schedule. So
Sure,
our next
I was going to make a quick comment.
Please go ahead.
Yeah, so I was just going to reiterate something you had mentioned earlier. One of the reasons it's very important to look at both training standard as well as quality guidelines is you can't, and you just gave a great example of why you must adapt or modify and merge the guidelines based on local needs and local availabilities. And so we absolutely need to partner, and it doesn't make sense. I mean, a lot of the talks we give and data we share applies to the US healthcare system or often the European healthcare system, but there are other limitations at times and other local needs of the population, of the individual patients that have to be taken into account. So I think as I can also congratulate the Pakistan Society of Interventional Cardiology, because I think it's really important for all of you to take lead in what works best in the local system, society, and culture.
Thank you. Thank you very much.